Hello everyone and welcome to Module 8, Communities and Social Systems. Your learning objectives are going to be to look at social stratification and how it plays a role in the health of populations, recognize how poverty and especially childhood poverty influences health and access to healthcare over the life course, and also look at some upstream and downstream measures for improving health. So when we look at communities all over the world, they all have some sort of way of classifying people into categories. This is called stratification. It can be done based on age, race, ethnicity, gender, class, occupation, to just name a few. Social stratification refers to a system by which a society ranks categories of people into a hierarchy based on socioeconomic status. Social stratification is based on four major principles. It is a trait of society, not simply a reflection of individual differences. It persists over generations. It is universal. It happens everywhere, but variable. It takes different forms across different societies. And social stratification not only involves inequality, but also beliefs. Movement in and out of these categories is seen as a product of individual capacities. In the case of race, ethnicity, and gender, it is believed that there can be no movement in and out. But I want to challenge you to think about movement in and out of the gender category, which is becoming more fluid. So we have previously talked about the need for population level data. This is especially true when we talk about social stratification, because the processes through which the social structure shapes the social circumstances and health experiences of different socioeconomic groups are very difficult to detect through the individual data on which health inequalities research relies on. Specifically, it is the absence of population-based health data and the reliance on individual medical diagnosis that makes these analyses problematic. I will give you an example at the end of this lecture on how collecting population-level data can be incorporated into electronic medical records. So when we talk about social stratification, it is closely tied to socioeconomic status and poverty. Poverty is associated with undermining of a range of key human attributes, including health. The poor are exposed to greater personal and environmental health risk. They are less well nourished. They have less information and are less able to access health care. Thus, they have a higher risk of illness and disability. Conversely, illness can reduce household savings, lower learning ability, reduce productivity, and lead to a diminished quality of life, thereby perpetuating or even increasing poverty. The poorer their socioeconomic status, the worse prospects for health development. This is where I want to bring you back to life course theory that you explored in Module 4. Evidence shows that one's experiences in childhood can influence patterns of illness, aging, and mortality later in life. Perhaps the strongest association between early life processes and adult health lie in the development of adverse health-related behaviors in childhood. This is why there has been an increased awareness of the important role of neighborhood community support and the built environment in shaping health-related behaviors and parenting norms. So when we look at childhood poverty, Wise points out in his article there are 4 opportunities that deserve special attention. Those are poverty reduction and parental well-being, early childhood intervention and parental support, managing the precursors to adult health and illness, and a commitment to the health of women. In reality, health changes throughout the life course, and individuals experience varying combinations of childhood and adult health. What is interesting in the Lee and Jackson article is that they looked at health trajectories. They plotted health over time, and they found 4 different trajectories. Person's health either deteriorated and then improved, or it continuously deteriorated, or they were only unhealthy during adolescence, or they were continuously healthy. So by creating these trajectories, we can identify persons at risk for poor health, and if we know who's at risk, we can then go ahead and design interventions at the crucial time point. Another important topic to discuss here is social inclusion and social exclusion in the community, which can be based on how people are stratified. There's a couple of definitions here we want you to be aware of. Segregation This is the separation or isolation of a race, class, or ethnic group by enforced or voluntary residence in a restricted area. An example of this would have been apartheid. Exclusion is the keeping apart, blocking of an entrance. Example of this would be people with disabilities unable to enter buildings without wheelchair ramps. Integration means the incorporation of individuals of different groups as equals into society or an organization. This is when a small group becomes part of a larger group, but it doesn't necessarily mean that the two groups intermingle or that the smaller group is included in all activities. Inclusion. This means that a person has the same rights, access, and choices as everyone else in the community. Inclusion is not considered a universal human right. It involves assuring that all support systems are available to those who need such support. So to give you an example, in Sweden, all people with physical disabilities, even quadriplegics, can live independently in the community in their own apartments, as they are provided with assistance that help them manage their ADLs. So therefore, the support system is available for these people to live independently. So how do we address this? I encourage you to go to the Rose article for this. In this article, they talk about upstream measures that really focus on social determinants of health. They also talk about downstream measures, which focus on self-management and lifestyle change. Albert Bandura, he's the one that defines self-efficacy as being a person's belief that he or she has the capacity and the competence to accomplish specified tasks. And we all know that self-efficacy is directly related to one's intrinsic sense of control. So, optimal outcomes in managing chronic illness integrates both self-management tasks such as self-efficacy into the medical care delivery system or upstream measures. So an example for you related to obesity would be that downstream measures approaches on direct dietary behavior interventions, such as individual nutrition education. This is probably the most familiar approach for health professionals working within an acute care system. Midstream approaches are more diffuse and target larger numbers of people, such as those using media to change food norms. Social marketing campaigns for public health interventions could be categorized as midstream approaches. Upstream approaches attempt to address the problem behaviors at their source. Upstream measures approaches include policies that change the food supply, providing a wide variety of healthy alternatives to choose from, or limiting access to unhealthy alternatives. Some examples would be limits on sodium and sugar content in foods. So going back to collecting population-level data on social structures. So traditionally, research and interventions on social and behavioral determinants of health have largely been the purview of public health, which has focused on disease prevention, protection, and promotion in the public's health. Healthcare systems, in contrast, have focused primarily on the treatment of diseases in the individual patients, and until recently, social determinants of health have not been linked to clinical practice or been of concern to the healthcare system. However, if standardized social and behavioral data can be incorporated into the patient electronic medical records, those data can provide crucial information about factors that influence health and effectiveness of treatment. And such information is useful not only for diagnosis and treatment choices, but also policy, healthcare systems, designs, and innovations to improve health outcomes and reduce healthcare costs. The IOM has put together a report that shows how electronic medical records can capture data about the determinants of health. For example, by having a patient address, you can plug that into a GIS system, and now you can identify this individual's access and resources and exposures to hazards. So I do recommend that you look at the IOM report, as it has some nice examples of screening questions for population-level data. So in summary, communities and social systems play a large role in our health. It is important that we incorporate both upstream and downstream measures when designing interventions. And remember, there's no discussion this week. You will be submitting your assignment number 2. Thank you.